Ce spectre de la santé digitale, il est large, il est complexe, il est sans cesse mouvant. Et donc, les équipes de la Fondation Pierre Fabre, elles le scrutent grâce à cet observatoire depuis plus de 6 ans. On rappelle, cet observatoire, il identifie, il documente, on envoie des gens sur le terrain, mener des enquêtes terrain, on répertorie véritablement les initiatives en e-santé dans les pays du Sud. L'observatoire, il faut le signaler, il est en accès libre, il est en accès gratuit, il a fait peau neuve sur odes.io et cette banque de renseignements, elle est aujourd'hui bien conséquente. C'est un travail unique qui est mené et pour vraiment se rendre compte de la valeur de ce travail, je vous propose d'en découvrir les principaux chiffres en images. Voilà, très très beau travail qu'on peut vraiment applaudir, mené par les équipes de la Fondation Pierre Fabre qui sont dans cette salle et aussi tous leurs partenaires qu'on a vus tout à l'heure. Et pour fournir toutes ces données depuis déjà 6 ans, je vous le disais, cet observatoire ne se contente pas de répertorier les initiatives. Il y a des équipes qui sont envoyées directement sur le terrain pour en savoir plus sur les déploiements des projets. Des spécialistes sont aussi envoyés sur place pour évaluer l'évolution des projets, cette fois-ci sur du très long terme, notamment les projets récompensés chaque année par les prix de l'Observatoire et appuyés derrière dans leur développement par les équipes de la Fondation Pierre Fabre. Et vous avez mené ce travail, Philippe Lepère. Vous êtes expert en santé mondiale après une longue carrière à l'étranger, dans des ONG, dans des institutions publiques. Vous avez beaucoup travaillé aussi pour ONU-SIDA. Et vous avez donc suivi 4 projets, entre autres sur du long terme, soutenus par la Fondation Pierre Fabre. Et on va s'attarder donc avec beaucoup d'intérêt sur vos conclusions. Alors, l'idée très claire dans les choses, c'est pas d'aller décerner des bons points ou des mauvais points à chaque projet. Ce n'est absolument pas l'idée de ce constat. On est dans une journée aujourd'hui sur la capitalisation. Donc l'idée, c'est vraiment d'aller voir quels sont les facteurs de réussite de chaque projet, les difficultés aussi qu'ont pu rencontrer les projets et comment tout le monde, qu'on soit en Asie, en Afrique ou en Amérique, comment on peut s'appuyer là-dessus pour se développer et aller plus vite. Et on va essayer de voir tout au long de cette session s'il y a de grandes règles générales finalement à respecter, s'il y a une synthèse que l'on peut faire de cette étude de projet. On va peut-être commencer, Philippe, par YEDA, qui est un projet qui est mené par l'ONG Terre des Hommes au Burkina Faso. Et on découvre tout de suite ce projet en images.
Ce qui a été révolutionnaire et décisif pour YEDA, c'est le fait qu'on a assez simplement finalement digitalisé des protocoles de prise en charge qui existaient, qui avaient été définis par l'OMS, mais qui étaient très difficilement applicables par les agents de santé au niveau périphérique. Donc, tout notre objectif a été justement de faire que ces protocoles soient plus appliqués qu'ils ne l'étaient auparavant. Et c'est en ça que ça a été révolutionnaire finalement, c'est qu'on a, avec du digital, apporté une réponse à cette problématique d'application des protocoles. C'est une co-création avec le ministère de la Santé. Cette approche, elle vise principalement à améliorer la qualité des soins qui sont prodigués au niveau des centres de santé périphériques, donc le niveau primaire du système de santé au Burkina Faso. Un des autres objectifs de IEDA est d'améliorer la qualité des données qui sont collectées et qui permettent justement au système de santé de construire leur politique et leur stratégie sur le pays.
Depuis 2018, on a élaboré un plan de transfert de technologie et également de la base de données sur les serveurs du ministère de la Santé. C'est une très bonne chose qu'IEDA puisse être repris par le ministère de la Santé, et en ce sens que cette reprise en main par le ministère de la Santé va permettre que la prise de décision puisse être faite sur des bases factuelles, parce que les données seront capitalisées par les systèmes de santé.
Voilà ce beau projet IEDA mené par Terre des Indes, entre autres au Burkina. Philippe, vous êtes allé sur place avec une belle originalité, mais aussi une belle réussite de ce projet. C'est un passage à l'échelle.
Because you've been scaling up this project. Answer. Well, yes. I think that is the only project that we have been able to scale up national level in this area of Africa. Normally, we have small pilot projects, what we call pilotype, that is to say small local projects. But here, as you can see here with the numbers, 85% of the overall territory, that's fantastic. Now, this is speaking of capitalizing and assessing the project. So it's a project, if I understood well, which you can assess easily when it comes to the impact on the different populations. Answer, yes, a few studies have been conducted, and you see that people consume less antibiotics, minus 15%, as you've seen on the slide, but we also have national indicators. And as shown by these indicators, there is an impact at several levels, that is to say, in terms of medical practice and for healthcare workers and professionals, things have changed. That is to say, the nurse is going to be close to the mother and for diagnosis with the mother. Instead of prescribing an antibiotic for a child who has fever, then he's going to start trying to help the mother to drop the fever with, let's say, a damp blanket, for instance. But this really has an impact on the medical practice, more proximity. And this means that today, if you have a mother who comes to the health center, if the nurse has a follow-up, she's going to leave because she's going to say, well, if you don't use a tablet, well, then I'm going to leave. But the mother is with the nurse and sees what's going on during the consultation. That's very important because they really have the impression that they share this, because when we reinforce the health system, it's really the well-being of clinicians and healthcare professionals, which is also another asset, another challenge, because the relationships can be much better with the patients if the healthcare providers feel better. This has a real impact when it comes to using this tablet. So this is very significant. And I must say that when we speak of capitalizing of assessments, well, we usually look at numbers, as I say, less antibiotics, and also how many people who are being treated. But we always forget that digital tools also imply a change, a modification in the relationship between patients and care health providers, because patients are embarked in this new approach. Yes, because if you only look into numbers and you forget that we have a better diagnosis, it doesn't help us to better give or distribute drugs, for instance, because you're not going to have the same indicators. Indicators are not going to change because you're always going to have the same morbidity rate, for instance. But you have to take into account the indicators, but also this relationship between healthcare providers and patients. Yes, because as you said, these indicators is something which will give us more information information concerning what the health providers do, but what about the relationship between the patient and the doctor, the physician, the nurse? We need what we call informal indicators. Answer, yes. Another indicator could be the expenses of the households, because if you have better treatments, if the treatment has an added value, then you don't come back and see the doctor. If your kid has fever, for instance, that means that you can be more available to go and work in the field. You don't have to spend money when you have to go to one point for another, so it helps the households. And if we look at the indicators of health improvement, that this makes a real difference. Yes, we've been speaking of very positive achievements with LIDA, thanks to these indicators. Now, is this a perennial, sustainable project? Answer, no, unfortunately. But this is something we're going to find with all the other projects. If you want it to be sustainable, you have to consider other factors, other items, and no project today is really sustainable for many reasons. I could go into this if you want to. For LIDA, for instance, the project has been scaled. It has been co-built and developed with the Ministry of Health, but the non-governmental organization has been implementing this, has been deploying this more rapidly than the ministry, because it has access to international funds the ministry doesn't have, and therefore, and the donors. So it's, I would say that it's a funding which is based on the results. So every 3 months you have to show that you have good results. So the ministry cannot keep up with that pace. So this is why the huge issue we have is how can we transfer this project to the Ministry of Health? Because the pace is not the same between the non-governmental, the NGOs, and the ministry. And the data is today being hosted in the United States. So we have a huge problem of transferring this data from the United States to the Burkina Faso. We also have another host center, which is in Oslo. So can you imagine what this means? Now, as we have scaled this project, we see here that the data is not being hosted by the Ministry of Health of Burkina Faso. And even though if they did, they don't have workforces for that. They don't have enough people, enough staff. So they couldn't use the data for their policy, their health policy. And another aspect is we don't know how much this project is costing, because we never had a real economic audit. We don't know how much this costs for each patient. So when we speak of sustainability, you need a business model. And this is something you will find in all projects. Yes, Philippe, I would like to come back for a few seconds. Okay, this is a fantastic project. It's 85% of the population which has been included in this project. And therefore, that means that you've been able to reach a population which doesn't always have access to medical treatments. We have an NGO which is very active, but maybe is going too fast, because as you said, the public institution can't keep up with that pace. Now, and the NGO is using tools that it controls very well, but sending data to the United States, to Europe. And this also means that from an environmental point of view, it's not the best approach. And you've said maybe we didn't take into account all the aspects when building up this project. Now, could you tell us if this is a problem with other files, other projects? Because if you start with NGOs, that means you start with a specific architecture. Maybe you have to reinforce this kind of structures to start with. Answer, well, Terre des Hommes has been a pioneer, because they have started developing this kind of project before we had this overall policy for digital health, before we had regulations, and therefore it's a learning by doing process, if I can say so. That is to say, they've been learning as they were doing. And this is something which is true for the NGOs and the government. There was no pre-established plan or program. It's a process which has been, I would say, growing progressively, and as it grew, it would start being rolled out and cross-fertilized. But now, I think that at this stage, we would have to see what are the lessons we can draw from this process. Because what scale should we have when we start with this kind of project? As I said before, we're not trying to rank these projects and saying this one is good, this one is not as good. No, what we're trying to show are all the projects which have been accompanied, which have been supported by the Pierre Fabre Foundation. Now, having said this, we have many NGOs who would like to have the same situations that we have in Terre des Hommes, because I must say that it's a rather comfortable situation and the results are rather good. And I would like to remind you that we're speaking here that we've been scaling this at national level, which is quite exceptional. Another project which has been supported by the Pierre Fabre Foundation is the 16B, that is to say in Cameroon, and the blood donors. So what about the traceability in this field? Now, to answer, I would say that Cameroon is in a special situation, because I've been moving around in the French-speaking African countries, and I've been rather surprised to see that there was no national strategy when you had these blood transfusion. It wasn't really secured. It's now being done, but there is no political will so as to secure the blood transfusion and the blood donors organization. Now, I think that in 1995, the manager of the Yaoundé National Hospital said, we have to do something about this. We have to improve the organization and have what we call blood banks. And they started doing this. They have a specific team now. They have premises for that. But he realized, in spite of this, that the follow-up would not ensure the traceability and the security which was required. And therefore, he said, well, we have to make sure we have more traceability at international level. And in Genby, in South Africa, started partnering with this blood bank. It's a concept which comes from a South African country, in which takes into account the African country's specificity. So they started establishing this partner. So I think that this is a success because this has been abiding by specific specifications. So there has been an organization. Well, I'll answer by saying that in France, we know that we have volunteers who give their blood. In Cameroon, people get paid for that. So you see, the software we have now tracks people, and people who come every week because they want to get paid for that. We say, no, you have to wait 3 months before you come back. So I think that's already a good tracking system. But we have other specificities at local level which are really embedded in the software. And I think that this is thanks to the partnership between South Africa and Cameroon, and they also have a certification of the Blood Transfusion African Society. So it's the only one we have which is now being digitalized. So that means we have a partnership between South-South, in which works, which is running. We have better traceability, at least for the institutions and persons who are working with this hospital. Now, I would say that nonetheless, there are some hitches, there are some weaknesses. Why? I wouldn't say that it's a tool which makes the difference and which is defective. I think that our government today is going to start reorganizing what we've done up to now, because so you have a tool which can be a robust tool, and you have other blood banks which are now being organized, but they don't have the tool and they have not received any kind of certification. So that means that you can duplicate the model? Yeah, why not? That would be maybe one of the rationales. But the organization has been given and trusted to the WHO. So what is the health organization going to do? Are they going to certify this tool? Now, if they choose another model, that means that the model we have, which works where, is going to become illegal. Now, I think that this is another aspect which we have to discuss. Before you scale the project, you have to ask the government if he accepts, and then the government says we have to look for a partnership with an international entity, and this is going to take time. This is going to be time-consuming. That means that your project is going to be a standby project, and we don't know how you're going to be able to scale this up, or the project is going to disappear. Another weakness in the PSSB project, which concerns probably 80% of the projects in e-health, is that very often it's a project which is based on trust, on relationships between men and women who are very motivated. But when you scale this up, it's more difficult, isn't it? Answer. Well, this is true. Literature never speaks about the human aspect of the projects and the human involvement. In the case of Cameroon, if we didn't have this involvement of Professor Fuga, we wouldn't have been able to set up this blood bank. So thanks to the manager of the hospital, we were able to do that. And I think that some people leave because they retire. I don't know what's going to happen when he is going to retire. Now, this is an autonomous blood bank, and he was able, as manager of the hospital, the executive manager of the hospital, to get financial support from the Ministry of Finance, but also he's been able to secure the budget he has in his own hospital for this blood data. So what's going to happen in the future? We don't know. So probably his leadership has been very important. In 3 or 4 years from now, I don't know what's going to happen. Is this project still going to be sustainable or not? Now, this is not only a subject or an issue which concerns the digital health, but it's something which concerns any kind of company. If you have a manager who has leadership, who is a pioneer, how can you prepare the transition when those persons leave, or when you have other companies or other organizations or entities coming in? How can you prepare this transition? How can you manage this? Because this is another possible weakness, and this is something you have to keep in mind when you launch a project. Now, another continent, another project we know because it's been awarded, it's Cushy Baby in India, and the Cushy Baby project is a project which has been developed in the northern part of India so as to facilitate the traditional healthcare system, which were rather poor, and also help remote population. They received an award from the foundation, GAFAB, a small collar small kids have, or where you have all the information, infants, for instance, where you have all the information concerning vaccines, and therefore if you have a tablet or phone, you get all the information which are in the pendant that or necklace that these babies or infants wear. And therefore there are other projects which have been cropping up, especially after COVID, and Cushy Baby now is working hand in hand with the Rajasthan Health Services. Now, Philippe, what do you think about this? What about the scaling up of this project, Cushy Baby? Well, this is the government of Rajasthan which has been rolling out this project. Now, if we look at AIDA, this is something different because this is something which started according the concept we have 30 years ago. That is to say, it's an NGO which started. Now, it's different because it's the government who started this, and Cushy Baby who is really the service provider. And therefore, the philosophy, the ideas have been I would say, cropping up thanks to the motivation of specific people who in the Rajasthan state in India were trying to have dashboards to see how they could manage the access to e-health. And when they started working with the ministry, when the Cushy Baby team started working with the government, well, they set up a specific community and they worked together. They've been collaborating, but all has been funded by the government today. So all the initiatives, salaries of the healthcare staff, and so all this has been funded by the government. Now, of course, research has not been funded by the government. It's been the budget of Cushy Baby for the tools, for instance. Now, Philippe, I would like to say that the government really wanted to digitalize health, and I think that this is something very specific specific to the Indian government. Yes, because you have Digital India, which was launched a few years ago by the Indian, so as to have a digitalized society. And the unique identifier and the access through digital tools. This is something we started a few years ago. Now, in Yeda, you also have this digitalized file, medical file, which will stay, which will be hosted in the health center. And this is also the case of Cushy Baby. You see here on these images that they have adapted. It was a pendant, it was a card, now it's just a sticker that you can use where you have all the information. And this is now being adapted. But you see, this is a model, a development model, which I think is very interesting, very challenging, because it's the government which is starting this, but working hand in hand with a company. Now, you said that in this project, something very specific is that the government works with a company and not with an NGO. Now, is this different from what we've just said before? Well, the difference is that the founders of Cushy Baby have been visionaries, they've been pioneers, because to start with, they've been working with a team of people who are very complementary one with another. You have different profiles, people coming from public entities, engineering, health sector. You have all the skills you need, and all the teams can work together. It's cross-sectional. It's a kind of sectional. You have a manager, but then you have really everybody at the same level. Everybody has a role to play because they can't do anything without the other people of the team. And that is why everybody really masters the tool. And this in a very startup environment. Yes, because when you speak with people, they say, well, of course I would be better paid at another company, a big company, but it wouldn't be as challenging and motivating. But now we work here all together and we are doing this for people, and that's why we feel happy. So it scales up. You work hand in hand with the government. So for Cushy Baby, that's fantastic.
Là aussi, on pourrait dire que tout roule, mais il n'y a pas eu d'évaluation économique, on ne sait pas combien coûte la prise en charge. Il y a beaucoup de choses, tous les aspects économiques n'ont pas été abordés. Et puis je dirais, s'il faut être un peu critique, c'est que leur faiblesse vient de leur force. En fait. Toujours, c'est comme ça, le facteur humain, c'est une équipe qui est très jeune, qui est très dynamique, qui travaille des heures et des heures, qui ne compte pas les heures. Mais la contrepartie, c'est de la jeunesse et du dynamisme, c'est peut-être un manque d'expérience. Et donc, dans l'équipe, il n'y a pas de...
Ça manque de vieux, quoi, ce que vous êtes en train de nous dire. On va dire les choses correctement. Dernier projet, dernier pays, on part au Bangladesh, cette fois-ci avec un autre projet qui a été primé ici, récompensé ici, donc encouragé, soutenu par la Fondation Pierre Fabre, qui s'appelle Tromaline, car le Bangladesh, on rappelle un petit peu rapidement les données, c'est un pays où il y a beaucoup d'accidents de la route et pas toujours forcément des moyens d'intervention d'urgence pour les victimes. Et Tromaline a formé des centaines de volontaires dans tout le pays le long des principaux axes routiers au premier secours. Ils ont formé 700 hommes, 60 femmes. Ils ont mis en place un call center qu'on peut appeler si on est témoin d'un accident. Et le call center, donc par géolocalisation, va aller géolocaliser des personnes qui ont été formées, qui sont volontaires pour aller tout de suite, immédiatement sur l'accident de la route, apporter des premiers secours. Et le call center va s'assurer aussi, va se mettre en relation avec les institutions publiques pour éventuellement déclencher des secours type ambulance, pompiers à venir derrière. Premier constat, avant de la faiblesse, premier constat, il ne faut jamais l'oublier, c'est un système qui permet de sauver des vies tous les jours au Bangladesh.
Oui, à plusieurs niveaux, parce qu'en fait, au Bangladesh, c'est une route qui est extrêmement meurtrière. Il y a une densité de près de 5 accidents par kilomètre par jour. Faut s'imaginer ce que c'est l'autoroute. Vous avez les bus qui foncent, le gars qui est avec sa moto qui, pour économiser quelques kilomètres, va remonter en sens inverse, va zigzaguer entre les bus, il y a le piéton qui va traverser. Et donc, il y a constamment des accidents et les gens qui habitent le long de ces axes routiers, par tradition, vont porter secours aussitôt. Et donc, au début, on s'aperçoit que les gens qui vont porter secours, qui ne connaissent rien en soins de l'urgence peuvent faire plus de mal que de bien, parce que quand on secoue un accidenté, on peut imaginer les dégâts qu'on peut faire. Et donc là aussi, c'est le facteur humain. C'est l'un des fondateurs de Chromalic a eu son papa qui est décédé d'un accident comme ça. Il a dit, je vais mettre en place une formation au premier secours. Et donc, l'idée première, c'était ça, c'était de former des bénévoles communautaires pour porter secours et porter des bons secours, faire les soins appropriés. Et très vite, l'idée géniale était de créer ce call center pour justement mobiliser très rapidement ces bénévoles de la communauté et surtout organiser la préhospitalisation et aussi faire venir les services de police, etc., pour éviter le suraccident. Donc, on sauve des vies en évitant le suraccident, on sauve des vies en intervenant dans ce qu'on appelle l'heure d'or, c'est-à-dire en moins d'une heure, la personne accidentée est transférée à l'hôpital. On sauve des vies en organisant l'ambulance, parce qu'il n'y a pas d'ambulance dans le pays, pratiquement. Là aussi, comme pour tout ce qu'on fait dans la santé numérique, on est victime ou tributaire des faiblesses du système de santé. Là, le problème, c'est les transports. Donc, le call center, une fois que l'accident est géolocalisé, s'occupe aussi de mobiliser les secours pendant que les bénévoles ne focalisent que sur la prise en charge de l'accidenté.
Et là aussi, comme dans de nombreux projets de santé digitale, autre point commun, on a une maîtrise tech qui est quand même impressionnante, un vrai savoir-faire avec ce call center et une capacité à géolocaliser des volontaires et à les déclencher. C'est pas rien.
Oui, et puis c'est d'autant plus extraordinaire que leur trousse de pharmacie est placée au bord de la route, parce qu'il y a plein de petites boutiques le long de la route, elle est toujours dans une des boutiques, et donc les volontaires sont mobilisés immédiatement, viennent de chez eux, ils savent que le matériel est déjà prépositionné, et ils peuvent intervenir, et ils savent que la police va arriver pour sécuriser l'accident.
Alors on voit une notion de service total, rendre service, sauver des vies, aller jusqu'au dernier kilomètre, c'est le cas de le dire, là on le fait, maîtrise de la tech, call center, géolocalisation, reconnaissance du savoir-faire, adhésion de la population, on forme également de la population par centaines au premier secours. Ça, ce sont tous les points très positifs de ce sujet. Embarquer les gens avec nous grâce au numérique dans les faiblesses.
Peut-être un point positif que j'ai oublié, mais qui me paraît très important, c'est une conséquence non intentionnelle du programme, c'est que les gens, les bénévoles sont tellement bien formés que dès qu'il y a un accident domestique ou un accident au champ, ce sont eux qui interviennent et donc permettent un désengorgement du système de santé.
Et ça, on ne le retrouve pas forcément dans des chiffres classiques d'une évaluation de projet. Ce sont les fameux éléments périphériques dont vous parliez tout à l'heure.
Dans les faiblesses, c'est des faiblesses un peu structurelles aussi. C'est le manque de financement de l'ONG. C'est une toute petite structure, Chromalic. Et à chaque fois qu'ils arrivent à mobiliser un petit financement, ils progressent par 10 km par 10 km. Et donc, ils sont à un carrefour. Soit ils continuent comme ça 10 km par 10 km, soit ils se posent et disent tiens, on va changer de dimension, on va mobiliser. Et donc là, ça suppose peut-être une réforme de l'institution, de l'ONG, de voir comment fonctionner si on change de dimension. Et la deuxième faiblesse, c'est que, contrairement par exemple au Burkina Faso, il y a une réelle volonté politique, ou en Inde, il y a une réelle volonté politique. Là, on est plus comme au Cameroun, où il n'y a pas de volonté politique de faire quelque chose. C'est-à-dire que la sécurité routière n'est pas une préoccupation pour le gouvernement du Bangladesh. Il n'y a pas de stratégie de sécurité routière, il n'y a pas de stratégie de prise en charge des accidentés de la route.
C'est-à-dire qu'à un moment, ceci c'est une constante, le passage à l'échelle est réellement complètement bloqué, impossible si la volonté politique ne suit pas. Il n'y a pas de pérennisation possible sans volonté politique.
Voilà, parce qu'en fait, il n'y aura pas d'intégration dans le système de santé, en tout cas. Et puis là, comme les autres projets, on n'a pas de modèle économique.
And as in many projects, we do not have an economical model or a business model. We don't know how much it costs to manage those accident
de chacun. Est-ce qu'on peut en tirer
So we've seen
des grandes règles générales que vous avez essayé de poser quand on va voir sur des diapos, Philippe?
We're going to have a few slides where we summarize the different keys for success or failure. Oh, that's a very difficult exercise because we're talking about very different contexts, different tools, different scales.
Ce que j'ai retenu, c'est que dans tous les cas, c'est comme avoir un puzzle à 4 pièces où les 4 pièces du puzzle doivent être assemblées pour avoir la pérennité. Donc, il faut un leadership, soit c'est un leadership du porteur de projet tout seul, comme dans le cas du Cameroun, soit c'est un leadership partagé, comme dans le cas de Couché Donc, le facteur humain est quelque chose d'essentiel, ça on l'a vu. Il faut des partenariats solides, donc là encore, c'est le facteur humain, avec qui ce leader va pouvoir créer les partenariats nécessaires. Il faut un environnement favorable. Donc il faut une stratégie de e-santé. Il faut respecter les droits humains, l'éthique, la confidentialité, la protection des données. Donc c'est vrai que le temps est un peu court parce que quel que soit le projet, j'aurais demandé est-ce que votre projet est développé en conformité avec la politique nationale ou avec la stratégie nationale? Et à chaque fois, je ne sais pas. Je ne sais pas s'il existe une stratégie. J'ai fait mon projet, je ne sais pas s'il y a une stratégie, je ne sais pas si c'est en conformité. Est-ce que votre projet respecte les lois du pays vis-à-vis de la protection des données à caractère individuel? À chaque fois, la réponse a été je ne sais pas. Donc ça, c'est des facteurs. Bon, il se trouve que j'ai recherché les stratégies, j'ai recherché les lois et tout c'était conforme. Donc il n'y a pas de problème. Mais c'est encore une fois des projets qui des fois se sont mis avant la création des lois, avant les trucs, mais tous ont développé leur propre éthique et donc appliquent des règles d'éthique internes à leur organisation. Il se trouve que ces règles d'éthique, bon, elles correspondent heureusement aux compliant with, again, for example, the data privacy regulations. I also mentioned about gender inequalities. You know, in Bangladesh, for example, there are a lot of inequalities, very, very high gender bias. Access to services is gender-based, and this, of course, not in favor of women. We have a lot more volunteers, 700 male volunteers, and only 60 female volunteers. Now, they're highly recognized, they were empowered, and this is an indirect consequence of this project, an empowerment of these women. This is what I called a favorable environment. This is also a key success factor for sustainability. We also need to work at the same time on the health system, because you can very well improve a sector of the health system, but if you do not have enough medicines, if you do not have enough stocks, if data are not properly used, then your tool is going to be pointless. There's no need in having a good diagnosis if then the patient has no access to the drug. We've seen that in Cameroon is not the case, so it's a daily challenge to really try to fight against this unfavorable environment. And then, of course, eventually, you need to have an economic assessment, see whether the project is supported by the health ministry, for example. The cost of a project needs to be assessed as well. And this is one of the building blocks that sometimes is missing. We have a hard time convincing health ministers because we do not have this overarching and comprehensive economic
ce puzzle un peu magique que vous nous donnez, 4 éléments. Vous dites vraiment il faut que ces 4 éléments soient dans le projet pour avoir un succès sur le projet que vous avez vu. Malgré les forces et les faiblesses, on n'arrive pas encore à avoir les 4 éléments. Et on voit bien que ce puzzle, il part du terrain, de votre observation de terrain, et non pas d'une observation de bureau qui redescendrait et dégoulinerait sur tout le monde. Ça, c'est important de dire. Merci, on peut applaudir Philippe Lepère pour cette présentation. Et on va donc poursuivre nos réflexions sur cette journée qui est consacrée à la capitalisation sur l'innovation en e-santé.